What's up sa inyo mga karoen? Magandang umaga sa inyo at sa inyo rin po Doc Chanko. Ngayong araw ay didiscuss natin ang Panoramic Radiography. So dito ay didiscuss natin ang history, syempre paano nabuo, ang principles, ang kanyang advantages, disadvantages, step-by-step procedures, indications, and also ang common errors na mostly nangyayari at diagnostic panoramic images.
Panoramic radiography, also known as panoramic imaging or pantomography. So sa isang ganitong radiography, pinapakita nito ang isang wide view ng ating maxilla and mandible, and also ang kanyang mga surrounding structures through single projection. Kumbaga, it allows for the visualization of the patient's oral and facial structures spread out across the surface. So bago tayo magpatuloy sa kanyang advantages and disadvantages, let's try to remember muna yung kanyang history kung paano ba nagkaroon ng panoramic radiography. The first attempts to image the whole jaw were made with intraoral radiation sources at the beginning of the 20th century. In the early part of the 20th century, many researchers were developing techniques using movement of the X-ray tube and the film para mag-visualize yung structures or foreign bodies like bullets na situated within the patient. Si André Pocage, correct me if I'm wrong, na isang French researcher, was the originator of the principles of body section imaging. Sa kanyang seminal work na napatent noong 1922, the author mentions the possibility of imaging curved surfaces katulad ng ating jaws. So after 20 years, X-ray equipment using two quite different radiographic techniques were produced para makakreate ng isang overall image ng jaws. First one, yung using intraoral source of radiation. So early as 1898 pa lang, na-propose na to ni Bouchard. Kaya lang, hindi pa ganun ka-clear. Nearly half a century later, concept was finally understood noong nag-submit ng patent ang German firm Koch and Sturzel noong 1943 at si Dr. Walter Ott ng 1951. So trivia lang, Dr. Ott's method was later refined by Dr. Sidney Blackman, resulting in the commercial production of ng panograph panoramic apparatus by Watson and Sons Limited. So as you can see on the picture on your left, ito yung patent na in-issue kay Koch at Sturzel of Dusseldorf, Germany for X-ray equipment capable of imaging body cavities. Si Horst Bergen is named as the inventor of the equipment. On the middle naman, it is the Panograph intraoral panoramic unit showing the slender X-ray tube. Itong intraoral panoramic equipment na ito, it uses a cone-shaped anode located at the end of a thin rod with a focal spot that was extremely small compared to conventional X-ray equipment. However, may mga inherent problems nga lang din to. It was extremely time-consuming, requires separate exposures for both maxilla and mandible. So as you can see sa right picture, where yung maxillary film is molded into the face, and also the technique also resulted in a severe geometric distortion, and more importantly, nag-deliver din ng high doses of radiation to the oral tissues, notably the tongue. So sino ba namang may gusto ng ganun? Further development of the intraoral type of panoramic equipment centered upon improving patient comfort and reducing image distortion. An eccentric positioning of the X-ray tube was an attempt to improve it. However, the problems of geometric distortion talaga proved insurmountable, or basically it is too great para ma-overcome. So next will be using extraoral source of radiation. So the records of the American Patent Office show na in 1922, a patent was issued to A.F. Zulauf for panoramic X-ray apparatus. The equipment used a rotational narrow beam X-ray technique that scanned either yung upper or lower jaw with an intraorally positioned waterproof lead-back film packet para ma-receive yung image. The X-ray generator was moved manually around the patient on a mobile carriage supported in a U-shaped table using a preformed track. Though kahit clearly understood yung principles of image production, meron pa ring limitations. Ni-stress ito ni Zulauf na the exact speed of the movement was determined by the experience and magdidepend sa strength ng X-rays, width ng collimator, at saka yung distance from the fifth being shadowgraph. While this patented design must qualify as the earliest example of rotational panoramic radiography, no further details concerning the subsequent development or clinical use of the equipment have been found. So as you can see sa picture, It is the patent of rotational X-ray equipment issued to A.F. Zulaf noong 1922. So the upper diagram is a side view elevation of the equipment. Tapos figures 4 and 5 as you can see sa picture, basically ito lang yung top and front views ng equipment na ginawa niya.
As mentioned in our previous lectures, patient dose reduction is of great significance when it comes to taking radiographs. Every possible method of reducing exposure to radiation should be employed to minimize risk. Thus, it is important to know the situations where panoramic radiography is best utilized to avoid retakes. Panoramic radiography produces panoramic images which can be used as the initial evaluation image. It can provide the required understanding or assist in determining the need for other projection and may serve as supplement to bite-wing and periapical images. It is indicated for patients who do not tolerate intraoral procedures well. This may be due to a strong gag reflex, and panoramic radiograph will provide us with an overview of their dentition. Panoramic radiographs also come in handy for diagnostic problems requiring broad coverage of the jaws, which includes evaluation of trauma and fractures in the mandible or in the mid-facial region, evaluation of tooth growth and development and eruption patterns, especially in the mixed dentition, evaluation and location of impacted teeth, evaluation of dentition and supporting structures such as periodontal bone loss, which is necessary to assess for the placement of dental implants. It can also be used in detection of diseases, lesions, and conditions of the jaws such as carcinoma in relation to the jaws and temporomandibular joint dysfunctions and ankylosis. Detecting retained teeth or root tips in edentulous patients, detection of developmental anomalies such as cherubism and pedicranial dysplasia, and examination of the extent of large lesions such as in cysts.
On to the next, we will now share with you the advantages of panoramic radiography. First off, simplicity. Panoramic radiography has many advantages, including short time for the procedure. This is because exposure of a panoramic receptor is straightforward and involves little effort and training on the part of the dental radiographer. Secondly, greater patient acceptance and cooperation. The panoramic radiograph is less confusing to the patient than a series of small, separate intraoral radiographs, making it easier for the dentist to explain the diagnosis and treatment plan to the patient. Next, overall coverage of the dental arches and associated structures. This means that more anatomic structures can now be viewed on a panoramic film than on a complete intraoral radiograph series. And not only that, the panoramic radiograph is an excellent imaging modality in patients with trismus or trauma, because such patients cannot open their mouths and this is not needed to take a panoramic film. Thus, it is an excellent projection of diverse structures on a single film, which no other imaging system can achieve. And lastly, low patient radiation dose. The dose to the patient is approximately 10 times less than full mouth survey using the long cone and E-speed film, and also it is 4 times less than 4 bite wings using the long round cone and E-speed film technique, which we all want, diba? And kung may advantages, syempre, meron ding disadvantages ang panoramic radiography kasi ika nga nila, nobody's perfect. First, distortion. This radiographic examination represents a lack of details and resolutions of some structures due to overlapping of anatomical structures in the image, distortion, and magnification. Next, limitations of focal trough. Objects of interest that are located outside the focal trough or the area of the dental anatomy that is reproduced distinctly on the panoramic radiograph are not seen, and artifacts are common and may easily be misinterpreted. In connection to the first disadvantage, since the image is superimposition of real, double, and ghost images, which will be discussed later, panoramic images requires careful visualization to properly interpret anatomic and pathologic details. With that, it also requires accurate positioning of the patient to avoid positioning errors and artifacts. And worry not, i-discuss natin to mamaya. Next is image quality, which is also a problem. This is because images are not as sharp as intraoral radiograph kasi nga made up of multiple stitch images siya. The sharpness and clarity are also reduced. Due to reduced sharpness and clarity, it cannot be used to diagnose caries. And lastly, cost. The cost of a panoramic machine is approximately 2 to 4 times that of an intraoral X-ray machine. And thus, we basically now have a gist of what is a panoramic radiography. But learning never stops. Let us now discuss its principles.
For the principles of panoramic radiography, one of which is the focal trough, which is used in dental panoramic imaging. This is one important principle to achieve maximum and clear panoramic radiography. Now, moving on to one of the principles of panoramic radiography is the focal trough. The focal trough determines where the dental arches must be positioned for the sharpest image. It is also known as the image layer. The focal trough is a three-dimensional curved zone in which features are clearly visible. When utilized properly, the focal trough generates a panoramic image that displays the position structures and shows up well-defined. On the other hand, the panoramic view may appear rather blurry or unclear due to the structures situated beyond the focus. The size and shape of the focal trough may vary depending on the manufacturer of the panoramic X-ray device. This variation can be seen when the focal trough is narrower, which means that the tooth rotation center is closer to the teeth. The focal trough of each panoramic X-ray equipment is designed to accommodate the average jaw. Manufacturers study the maximum details of patient positioning guidelines so that the teeth are fit when positioned within the focal trough. For the quality of the resulting panoramic image, it is important to carefully conform to the placement of the patient's teeth within the focal trough. In addition, the degree to which the patient's maxilla and mandible must be exact to the focal trough as it is established for the average jaw. These guidelines must be followed to ensure quality results.
Image distortion. This refers to the non-proportional increase in dimension of a radiographed object relative to the actual dimension of that object. The positioning of the patient's head within this type of equipment is very critical. It must be positioned accurately so that the teeth lie within the focal trough. The following are diagrams showing the position of the mandible in relation to the focal trough when the patient is not positioned correctly. For letter A, the patient is too close to the film and in front of the focal trough. For letter B, the patient is too far away from the film and is behind the focal trough. For letter C and D, the patient is placed asymmetrically within the machine. The parts of the jaw outside the focal trough will be our focus. The fan-shaped X-ray beam causes patient malposition to be represented mainly as distortion in the horizontal plane. For example, the teeth appear to be too wide or too narrow rather than foreshortened or elongated. Thus, if the patient is rotated to the left, as shown as in figure C, the left teeth are nearer to the film and will be narrower, while the teeth on the right will be further away from the film and is wider.
Ngayon naman, pag-usapan natin ang resultant images. Some anatomic structures are penetrated twice by the X-ray beam because of the rotational imaging process during the panoramic exposure cycle. The location of these structures determines what type of image results. The distinction between resultant images is based on the position of the object relative to the X-ray source, the rotation center, and the receptor. It can be a real image, a double image, or a ghost image. A real image is a true image. It results when a structure lies between the receptor and center of rotation. It appears in the correct anatomic location with varying degrees of sharpness and distortion. Lumalabas na sharp images ang mga structures that lie within the focal trough. Blurred images naman ang mga structures outside of the focal trough. On the other hand, a double image is also called a mirror image or the reverse of the real image. It results when an anatomic structure that is located posterior to the center of rotation is penetrated twice by the X-ray beam. It has the same proportions as the real image, and it is located in the same location on the opposite side of the receptor. Ang examples nito ay ang mga structures located at the midline such as the epiglottis, hyoid bone, and cervical spine, all of which cast images on both sides of the panoramic receptor and form double images. Lastly, a ghost image. It results when an anatomic structure or object is located outside of the focal plane and close to the X-ray source. It resembles its true image and is found on the opposite side of the receptor. It appears blurred, magnified, and higher than the actual counterpart because the structure is far from the focal trough. A ghost image appears higher than the true image as the result of the negative vertical angulation of the X-ray beam. Anatomic structures that are located laterally, such as the ramus of the mandible, or located centrally, such as the hard palate, can produce ghost images. Objects located laterally, such as earrings, can also produce ghost images.
Now, as we delve deeper into panoramic imaging, tignan natin kung anong meron sa machines na ginagamit para dito. Panoramic machines come in various forms. Yung iba film-based, while yung iba are digital radiographic machines. Ibig sabihin lang nun na may machines that may use a direct digital sensor, a photostimulable phosphor plate, or a radiographic film. What I'm showing you right now is a film-based unit. Then yung mga example mamaya is more on digital units na. Such as itong tatlo. Yung first photo being the VeraView Epox from Japan, which makikita nyo may arm attachment pa siya for Ceph imaging naman. Second photo is the GXDP700 from Pennsylvania. Ayun mukhang standard unit. While sa C, although same lang naman, this image of the Pro 1 from Illinois shows how yung mga panoramic X-ray machines are versatile enough to allow us to use them on many various kinds of patients. Maski matangkad, nakaupo, or bata, matanda, or kahit anong gender. Now, kahit iba-iba yung machine per manufacturer, a common thing among them is that lahat sila may X-ray tube head, a head positioner of some sort, and yung exposure controls or control panel. The panoramic X-ray tube head, tulad ng na-discuss na dati, also contains a filament that generates electrons and the target used to produce X-rays. Yung collimator nun, instead of being round or rectangular, is now a long, narrow vertical slit, allowing it to capture the radiographic image ng mas matatangkad na group of structures, tulad ng kung ano yung scope ng panoramic, going from levels as high as the maxillary sinus. Tapos di ba nga, pati yung orbit nakikita pa sa image, and then down to the inferior edge ng chin. Sa panoramic imaging, isang vertical angulation lang ang ginagamit, allowing the X-ray beam to be directed slightly upward at approximately -10 degrees. Today, we won't talk about the horizontal angle kasi sa panoramic radiography, yung X-ray tube head ng machine, it revolves almost halfway palibot sa likod ng head ng patient. And in that sense, yung receptor naman is the one that revolves around the front of the head of the patient. The head positioner naman allows for the alignment of the patient's teeth as accurately as possible sa focal trough na na-discuss na kanina. And altogether may consist of the chin rest as can be seen sa lower photo, the notch bite block, then yung makikita sa second photo na forehead rest, and of course yung lateral head supports. So mamaya, yung pinaka-alignment ng head ng patient gamit tong devices na to would be discussed ng mga mas nakakaalam sa akin. And last but not the least, exposure controls or yung tinatawag natin na control panel serves to be manipulated by the practitioner para makuha yung correct settings for milliamperage, kilovoltage, and time, which may differ from a case-to-case basis. Depende sa recommendations of the manufacturer or the physical features of the patient. In this clip, makikita natin yung exposure factors which will come up next. Ayun, since napapag-usapan na din naman natin yung mismong control panel, I would like to tell you about the exposure protocols bago natin mapag-usapan yung mismong application ng knowledge onto the patients, yung positioning and yung exposure proper, mga ganun. Specifically, this will be about the kilovoltage, milliamperage, and exposure time. So according to the 3 books na gagamitin natin for our röntgenology under the ever so lively Doc Chanko, we are to follow the settings recommended by the manufacturer ng panoramic X-ray machine na gagamitin natin. Also, we are encouraged to adjust the settings based sa size ng patient, as was stated by Ian Ritchie. Academic sources regarding sa specific ranges ng exposure factors were scarce, but luckily, madaming user manuals for various panoramic X-ray machines na available online. And doon natin makikita yung manufacturer recommendations na sinasabi ko kanina pa. So straightforwardly, yung ranges ng exposure factors for a standard panoramic radiograph are as follows. Yung kilovoltage is around 60 to 85 kVp. Yung milliamperage is around 4 to 10 milliamperes, while yung exposure time naman is around 13.5 seconds, mga ganun. Of course, like I mentioned, we just follow the manufacturer's recommendations. So the specific settings can vary sa iba-ibang user manuals. Pero one manual in particular, for an X-ray machine made by an Indiana-based company, has this to say. Nire-reflect nga yung isa sa biggest lesson na ini-instill ni Doc Chanko sa utak natin, which is to use the least dosage as diagnostically possible. Of course, di naman pwede na basta-basta na lang natin babaan yung settings na hula-hula lang. It comes with experience, but still, the point is there, no? Patient dose reduction is among our goals in practice. Next nating pag-uusapan is yung mismong procedures in panoramic imaging. Pero may ibang tao na may mas alam sa akin tungkol doon, so take the mic guys.
Bago gawin ang panoramic X-ray, importanteng i-calibrate muna ang equipment para maging successful ang radiography. First, prepare the receptor. When using film, mount the panoramic cassette and ensure that the cassette is under safe light circumstances and if possible, in a dark room. Inside the cassette, insert 1 extraoral film and 2 intensifying screens. Then close firmly and place the tape into the panoramic unit's cassette carrier. Second, prepare the bite block. On top of the bite block, place a disposable plastic cover slip. This biting block should be sanitized after patient use if it is not covered with an impervious material. Lastly, choose exposure settings. Adjust the exposure factors such as the kilovoltage, milliamperes, and time. Ensure to follow the manufacturer's instructions upon doing so. Elevate the machine according to the patient's height as needed.
Kung may equipment preparation, there is also a much needed patient preparation. Explain the imaging procedure. First, it is important to briefly explain the imaging procedure to the patient. It may also be wise to demonstrate the machine to the patient by cycling it while explaining the need to remain still during the procedure. And this is particularly important for children who may be anxious. Since ang mga bata ang kikit niyan at puno ng curiosity sa buhay, children should be instructed to look forward and not to follow the tube head with their eyes. Next, place a lead apron. Place and secure a lead apron without the thyroid collar of the patient. The use of a thyroid collar or improper lead apron placement will block the X-ray beam and prevent imaging of structures at or near the midline, resulting to the lead apron artifact seen lateral to the lead apron. Place the lead apron low around the neck so that it does not block the X-ray beam, and use a double-sided lead apron to protect the patient. Lastly, remove all objects. As Doc Chanko discussed in her lecture before, we have to make sure to request that the patient remove all objects such as dental appliances to avoid the sample radiograph here, earrings, necklaces, hairpins, and any other metallic objects from the head and neck area that may interfere with the procedure. Moving forward, patient positioning is extremely important in panoramic procedures because of the length of time needed to acquire the panoramic image. Therefore, it is important that the patient be as comfortable as possible during the procedure. First, position the spine of the patient. Instruct the patient to sit or stand as tall as possible with the shoulders back and their necks extended. If the patient is not standing or sitting with a straight spine, the cervical spine appears as a radiopacity in the center of the field and obscures the diagnostic information as pointed by the black arrows. Next, the spine must be perfectly straight. Having patients place their feet on a foot support and using a cushion for back support may facilitate proper back positioning in seated units. Proper neck extension is best accomplished by using a gentle upward force on the masseter eminences when positioning the head in a manner similar to applying cervical traction. Allowing patients to slump their heads and necks forward causes a large opaque artifact in the midline created by the superimposition of an increased mass of cervical spine. This will be further discussed later and showed later by my fellow groupmates. And this shadow obscures the entire symphyseal region of the mandible and may require that the radiograph be retaken, already violating yung principle natin na limited patient tools lang. Next, we position the teeth. Instruct the patient to bite in the groove located on the plastic bite block, a notched positioning device, and this will align the teeth in the focal trough. Position the incisal edges of the maxillary and mandibular anterior of the patient in an end-to-end position in the groove on the bite block. This captures the anterior-posterior position radiograph of the patient. The next thing we need to position is the head alignment. Most panoramic units have laser beams to facilitate alignment of the patient's mid-sagittal plane, Frankfurt plane, and anterior-posterior position within the focal trough. To be precise, position the mid-sagittal plane or an imaginary plane that divides the patient's face into right and left sides perpendicular to the floor. The mid-sagittal plane must be centered within the focal trough of the particular X-ray unit. Placement of the patient either too far anterior or too far posterior results in significant dimensional aberrations in the images, which are to be again discussed later in common errors in panoramic radiography. Next, position the Frankfurt plane or an imaginary plane naman that passes through the top of the ear canal and the bottom of the eye socket parallel to the floor. And the patient's head must not be tipped up or down, and the patient's chin and occlusal plane must be properly positioned to avoid distortion. The occlusal plane is aligned so that it is lower anteriorly, angled 20 to 30 degrees below the horizontal. A general guide for chin positioning naman is to place the patient so that a line from the tragus of the ear to the outer canthus of the eye is parallel with the floor. And again, any deviation from this positioning will result in inevitable radiographic errors, which will be again further discussed later. Lastly, we position the lips and tongue. Instruct the patient to place the tongue on the roof of the mouth and suggest that the patient swallow once muna and feel the tongue rise up to the roof of the mouth and keep it that way or keep the tongue in that position during the procedure. This raises the dorsum of the tongue to the hard palate, eliminating the air space and providing optimal visualization of the apices of the maxillary teeth. And instruct the patient to close the lips around the bite block. And that's it. For the final instructions and exposure, instruct the patient to remain still while the machine is rotating during exposure. And the final step, expose the receptor.
After knowing how the patient is positioned and prepared, we now go to film positioning. We all know that this is an important aspect in radiography to avoid errors and ensure a diagnostically acceptable image. When it comes to film positioning in extraoral radiography, specifically in panoramic radiography, films are contained in a cassette which is placed inside of the machine, unlike in a traditional intraoral X-ray, where the film is placed inside the patient's mouth using an intraoral film holding device. Looking at a panoramic X-ray machine, it has two sides. On one side is the mounted X-ray tube, while on the other side is where the X-ray film is placed inside. Rather than relying on film placed inside the mouth, a panoramic X-ray machine projects a beam through the patient onto the film or a detector rotating opposite the X-ray tube. The X-ray tube on one side and the receptor, which could be the panoramic conventional X-ray film or digital sensor, moves around the patient in opposite directions.
So ngayong napwesto na natin yung film or at least alam na natin nasan yung receptor, itututok na natin yung central ray based on the landmarks that we can use. So in pointing the central ray, there are only two ideas to know about, which is yung proper patient positioning and that yung tube head, it automatically returns to position once pinindot natin yung button for that. Tulad ng na-mention kanina, meron tayong vertical and horizontal alignment na kailangan tignan. And ang katulong natin sa part na to would be yung laser indicators. And yung patient mismo, syempre, mas maganda kung nakikiko-operate sila, no? So, once na-press and naka-on na yung laser indicators, that is the time to apply yung knowledge natin sa patient positioning. Yung vertical laser, as was mentioned, nakatutok sa mid-sagittal plane. And among the guides na pwede natin magamit for this one is yung nose ng patient and yung central incisors. If ever man, normal naman yung midline ng dentition nila.
Yung horizontal laser naman, remember Frankfurt plane. We use the porion and orbitale pyogen, which are the inferior border of the orbital margin and yung superior border ng external auditory meatus respectively. Once aligned na lahat, we can proceed with the exposure, knowing that the tube head automatically achieves its correct position once na napindot na natin yung reset button after each and every case. It is advised na nakaalis na dapat muna yung patient away from the machine bago natin i-reset yung position ng overhead. So that's it for central ray projection. Take it away, guys.
Interpreting panoramic images. There is less superimposition of features and hence less of an interpretation challenge because panoramic views are curved picture or slices of the mandibulofacial tissues. It's beneficial to look at the image as if you're looking at the patient, with the structures on the right side of the patient positioned on the viewer's left. As a result, the image is displayed in the same orientation as periapical and bite-wing images, making this interpretation easier. It is critical to recognize the patient's planes as they are portrayed in various portions of the panoramic image. The panoramic image depicts a bent jaw that has been flattened out. Basically, it displays a sagittal or lateral view of the jaws in the posterior regions, while it depicts a coronal or anterior-posterior view in the anterior sextant. In this slide, medyo nakaka-intimidating pa, no? Since maraming structures ang nakikita in the panoramic radiography. But don't worry, my group will do our best to discuss with you each of these structures. First and foremost, as mentioned sa advantages kanina, the strength of the panoramic image is the demonstration of the complete dentition. Thus, ito ang una natin i-discuss. Although the patient's position or an ectopic tooth may cause the tooth to be out of the focal trough, all of the teeth are usually seen on the image. As a result, all erupted and developing teeth must be identified during the interpretation. In this sample radiograph, we can see that the patient had a complete set of their teeth, di ba? Sana all. We know this because we must first know or na-master na natin dapat ang anatomy of the tooth to recognize alin ba dito yung 1-1, 1-2, 1-3, and so on and so forth. The teeth should be examined for abnormalities of number, position, and anatomy. Existing dentistry, including endodontic obturations, crowns, and other fixed restorations should also be noted. Excessively wide or thin anterior teeth indicate that the patient is positioned incorrectly in the focal trough. Teeth that are wider on one side than the other, on the other hand, indicate that the patient's sagittal plane has been rotated. And further examples will be presented later again in the errors. Gross caries, periapical, and periodontal disease are all possibilities. Nevertheless, as mentioned din kanina, panoramic radiographs have a lesser resolution than intraoral radiographs, hence further intraoral radiographs may be required to detect mild illness. And furthermore, the proximal surfaces of the premolar teeth frequently overlap, kaya making yung interpretation ng caries difficult. It is particularly important to examine impacted third molars closely. Kadalasan, di ba, during our oral path, panoramic radiograph ang nakikita nating example when we were discussing about the different classification of impacted third molars. This is because the orientation of the molars, the number and configuration of the roots, the relationships of the tooth components to critical anatomic structures like the mandibular canal, the floor and posterior wall of the maxillary sinus, the maxillary tuberosity and adjacent teeth, as well as the presence of abnormalities in the pericoronal and or periradicular bone must all be carefully examined, and the panoramic radiography provides just that. For instance, this panoramic radiograph shows bilateral impacted mandibular third molars and their relationship to the mandibular canal. Due to the two-dimensional nature of the panoramic image, additional imaging, however, with cone beam computed tomography or CT imaging may be required to establish precisely the spatial relationships of the impacted molar roots to the important structures.
Now, let's move on to the structures that are seen on the midfacial region. First off is the external auditory meatus. Appears as a round or ovoid radiolucency, anterior and superior to the mastoid process. The pterygomaxillary fissure appears as a radiolucent area between the lateral pterygoid plate and the maxilla. The infraorbital foramen appears as a round radiolucency, inferior to the orbit. The orbit appears as a round radiolucent compartment with radiopaque borders, located superior to the maxillary sinuses. The anterior nasal spine. This appears as a V-shaped radiopaque area, located at the intersection of the floor of the nasal cavity and the nasal septum. This is also viewed in intraoral images. The nasal septum appears as a vertical radiopaque partition that divides the nasal cavity. Beside this is the nasal concave. The hard palate appears as a horizontal radiopaque band superior to the apices of the maxillary teeth. The zygomatic process of the maxilla appears as a J or U-shaped radiopacity located superior to the maxillary first molar region. The glenoid fossa appears as a concave radiopacity superior to the mandibular condyle. The articular eminence appears as a round radiopaque projection of the bone located anterior to the glenoid fossa. The maxillary tuberosity appears as a radiopaque bulge distal to the third molar region. maxillary sinus, and floor of the maxillary sinus. Appears as a paired radiolucent area located superior to the apices of the maxillary premolars and molars. Zygoma appears as diffuse radiopaque band that extends posteriorly from the zygomatic process of the maxilla.
Dumako naman tayo sa mandible. Pwede rin natin itong i-categorize into its major anatomic areas. These are condylar process and TMJ, coronoid process, ramus, body and angle, anterior sextant, and mandibular dentition and supporting albulus. The glenoid fossa is the concave area in the zygomatic process of the temporal bone. It is a key component of the temporomandibular joint. Medial to the glenoid fossa, we can see the articular eminence. The glenoid fossa can be pneumatized by the mastoid air cells, which can result in the appearance of a multilocular radiolucency in the articular eminence and the roof of the glenoid fossa, which is a variant of the normal. The mandibular condyle is seen as a rounded, radiopaque area located within the glenoid fossa towards the lateral aspects of the panoramic film. Since the patient has to open and protrude, the mandible is likely to engage the positioning device in most panoramic machines. The mandibular condyle is generally positioned slightly antero-inferior to its normal closed position. The coronoid process is found medial to the condyle as a radiopaque, triangular area. It may superimpose over the maxillary tuberosity and the maxillary sinus. If we then follow on down from the condyle and coronoid processes, we reach the ramus of the mandible. This then leads on to the body of the mandible, and the location this join at is the angle of the mandible. May mga shadows naman ng ibang structures ang pwedeng masuperimpose over the mandibular ramal area. Kabilang na dito yung pharyngeal airway shadow, posterior wall of the nasopharynx, cervical vertebrae, earlobe and ear decorations, nasal cartilage and nasal decorations, soft palate and uvula, dorsum of the tongue and tongue decorations, and ghost shadows of the opposite side of the mandible and metallic jewelry or piercings. Within the ramus of the mandible and going through the body of the mandible, you will notice a radiolucent band which is surrounded by two radiopaque bands. This is the inferior alveolar nerve canal, where the inferior alveolar nerve travels through. This will then travel to a radiolucent ovoid area around the apices of the lower first and second premolars. This is the mental foramen. The mental nerve exits from here. Dapat din nating tandaan na bulging of the canal suggests a neural tumor. Pero, slight widening at the point that the canal bends to enter the body of the mandible from the ramus is a variation of normal. Hindi rin pahuhuli yung favorite nating parang bubong ng Sydney Opera House na band of inverted V-shape radiopacity, the so-called mental ridge, ay makikita natin sa gitna. At yung tiny bump radiopacity na genial tubercle ay makikita rin natin. There are often depressions on the lingual surfaces of the mandible, which are occupied by the submandibular and sublingual glands. These depressions are termed the lingual salivary gland depression or submandibular fossa. Madalas makita ito as radiolucent. This concavity is often found on the posterior lingual surface of the mandible. This triangularly shaped area is bounded by the mylohyoid ridge superiorly in the inferior border of the mandibular body and lies in the region of the roots of the molars and premolars. Lastly, the lower border of the mandible is seen as a thick radiopaque band. The mandible should be examined for radiolucencies or opacities. The midline is more opaque because of the mental protuberance, increased trabecular numbers, and attenuation of the beam as it passes through the cervical spine.
We will now proceed to the soft tissue structures and air spaces which can be seen in panoramic images. Soft tissue structures are less dense than bone. Thus, they appear less radiopaque than the calcified structures in radiographs which were discussed in the previous slides. Air spaces, on the other hand, appear radiolucent. Numerous opaque soft tissue structures may be identified on panoramic radiographs, including the tongue, lip markings, the soft palate, the posterior wall of the oral and nasal pharynx, the earlobes, the nose, and the nasolabial folds. The epiglottis and thyroid cartilage are also often seen in panoramic images. Radiolucent airway shadows superimpose on normal anatomic structures and may be demonstrated by the borders of adjacent tissues. They include the nasal fossa, nasopharynx, oral cavity, and oropharynx. The soft tissues create indistinct radiopaque shadows which superimpose over the osseous and dental structures. Now I will show you the soft tissues seen in panoramic radiographs. First, we have the tongue. Arching across the image under the hard palate approximately from the area of the right angle of the mandible to the left angle. Next, we have the soft palate, extending posteriorly from the hard palate over each ramus. Next, we have the earlobes. The soft tissues of the external ear are often seen superimposed over the mandibular condyle with the earlobe forming a rounded radiopacity posterior to the ramus. Next, we have the nose, which may be seen over the epicels of the maxillary incisors with the ala curving laterally from the midline. Above it, we can also see the nasal septum. At the sides, we can also see the posterior pharyngeal wall. In this radiograph, we can see better the nasolabial folds, while in this radiograph, we can see the lip markings, which is in the middle of the film. The areas of the teeth covered by lips appear more radiopaque. Here we can see the thyroid cartilage, as well as the epiglottis, which can often be seen as a thin finger-like projection extending from the posterior tongue below the angles of the mandible. Summarized in this slide are the following. We have the tongue shaded with yellow, we have the soft palate shaded with red, we have the earlobes shaded with pink, we have the nose shaded with blue, with the nasal septum shaded with green, the posterior pharyngeal wall shaded with orange, and the addition of the middle and inferior turbinate shaded with violet. Shown here are the nasolabial fold, outlined with yellow, and the lip marking, outlined with green. Last, we have the thyroid cartilage shaded with red, and the epiglottis shaded with green. Let us now proceed to the air spaces seen in panoramic images. The upper airway includes the nasal fossa, oral cavity, and oropharynx, all of which are imaged on the panoramic radiograph as radiolucent passages. These radiolucencies may be confused for bone-destroying pathology or fractures. The nasal fossa, which is pointed by the yellow arrow, is seen in the midline, superiorly, and extends bilaterally across the region of the maxillary sinuses. Posteriorly, it opens into the nasopharynx. The nasopharynx, which is pointed by the green arrow, is seen posterior to the maxilla and superior to the soft palate. It is continuous with the oropharynx inferiorly. The oropharynx, which is pointed by the purple arrow, occupies the region anterior to the cervical spine and posterior to the tongue. Last, we have the oral cavity, pointed by the blue arrow, which is a radiolucent strip between the superior surface of the tongue and the palate. In this radiograph, pointed by the red arrow is the airspace between the dorsum of the tongue and the soft palate. It stimulates a fracture through the ramus or angle of the mandible. Thus, it is important to be familiar with this anatomic landmark so that it will not be mistaken for a fracture.
Balikan naman natin saglit ang density at contrast. Katulad sa isang math formula, there are factors that we combine to get a diagnostic panoramic image. These are adequate exposure and proper density and contrast. The relation of exposure to the patient is directly proportional. In density, it must be balanced and not excessive. An ideal contrast allows identification of the junction between enamel and dentine in the molar region. Kapag naman underexposed or overexposed ang image at inadequate ang contrast, it may cause problems with detection of unerupted teeth or bony lesions. At oops, wag mag-alala. Kapag overexposed ang image, may pag-asa pa. It can still be corrected with the use of software in digital imaging.
To come up with a diagnostically acceptable panoramic image, errors must be avoided. Usually, errors are due to patient preparation errors and patient positioning errors. The following preparation errors are ghost images and lead apron artifact, while patient positioning errors are the positioning of the lips and tongue, chin tipped up or down, teeth anterior or posterior to the focal trough, head turned, and slumped posture. Even simple errors could lead to images that are not diagnostically acceptable. That's why one must know and understand what these errors are, how it affects the image produced, and how to correct them.
The first common error is ghost images. The cause of this is that the metal and dense objects aren't removed before the panoramic receptor is exposed. Due to this, a radiopaque artifact is seen when a thick object is situated outside the focal plane and near the X-ray source. A ghost image can be likened to its counterpart and may appear on its opposite side, appearing much more fuzzy, larger, and taller than the counterpart. To correct this, the dental radiographer must have the patient remove all dense or thick objects from the head and neck, such as earrings and accessories.
So next is the lead apron artifact. Paano ba ito nagkakaroon? So kapag yung lead apron ay incorrectly placed on the patient, a radiopaque cone-shaped artifact will be developed. And dahil dito, it will obscure the diagnostic information. Or kumbaga, kung yung lead apron ay may thyroid collar, tapos ginamit during the exposure of a panoramic projection, magkakaroon ng bilateral radiopaque artifact that will obstruct the mandible. So solution, paano ba natin ito ma-solve? Anong kailangan i-prevent? Or anong kailangan gawin? Para ma-prevent itong ganitong artifacts, dental radiographer ay dapat gumamit ng red apron without a thyroid collar. So, kailangan niya gumamit nito na walang thyroid collar when exposing a panoramic projection. It must be placed low around the neck of the patient also para hindi mablock yung x-ray beam. And in addition, the primary beam in panoramic imaging is directly slightly upward, and the area of the thyroid gland must receive little or no less radiation dose. So, as you can see sa picture, yung halatang kitang-kita yung thyroid collar artifact sa baba. Ayan yung kulay white, ayan yung thyroid collar. So, sino bang may gusto ng ganitong x-ray? Nakita yung thyroid collar? Siyempre, wala. So, next, we'll proceed to patient positioning errors. So, first one, positioning of lips and tongue. So, this problem occurs if the patient lips are not closed on the bite block during the exposure of panoramic projection, and it will result in a dark radiolucent shadow na mag-obscure sa anterior teeth. This area of increased darkness occurs over the maxillary anterior region, and baka ma-misjudge siya na bone loss. Ayaw naman natin ng ganun, syempre. So, also, if the tongue is not in contact with the palate during the exposure of a panoramic projection, meron ding dark radiolucent shadow na makikita that would obscure the apices of the maxillary teeth. Although, failure na may position yung tongue on the roof of the mouth is one of the most common patient positioning errors, it rarely requires a retake. So, minsan yung ibang nag-x-ray, hindi na nila pinapa-retake. Solution, para ba natin to may iwasan or masasolve? Para ma-prevent naman to, dapat i-instruct ng dental radiographer yung patient to close the lips around the bite block. The patient must then be instructed na mag-swallow once and to hold the tongue against the hard palate during the exposure of the projection. So, dito sa image, you can see a radiolucent shadow that will be superimposed over the apices ng maxillary teeth if the patient does not keep the tongue against the palate throughout the entire exposure.
The next patient positioning error is chin tipped up. In this error, as seen in the photo above, the patient's chin is too high or tipped up with a Frankfurt plane angled upward. When the patient is positioned in this way, the resulting radiograph will look like the one in the bottom, and as you can see, the most evident indication of a chin tipped up in the radiograph is the reverse smile line. Also, the condyles do not appear near the lateral edge of the image, and in addition to this, the mandible is squared off, and there is a loss of detail in the maxillary incisors, and their roots appear short. Lastly, the hard palate and the floor of the nasal cavity appear superimposed over the roots of the maxillary arch. To correct this error, the patient should be positioned in a way that the Frankfurt plane should be parallel to the floor. Another error due to positioning of the patient is chin tipped down. As seen on the photo above, the patient's chin is too low with the Frankfurt plane angled downward. Because of this, the resulting radiograph will look like the one below, wherein the most evident indicator is the exaggerated smile line. You can also see on the radiograph that there is a loss of details in the anterior apical regions, and the mandibular incisors appear blurred with their roots shortened. The mandible also appears to be V-shaped as it is widened vertically on the radiograph. Correcting this error will be the same with the error chin tipped up, which is to make the patient positioned in a way that the Frankfurt plane should be parallel to the floor. The next error is teeth anterior to focal trough. As the name implies, it occurs because the patient's anterior teeth is positioned too far forward on the bite block, as seen on the photo on the left. This will then result in the radiograph as seen on the right, wherein there is a visible narrowing and blurring of the anterior teeth. There is also a pronounced overlapping of the premolars. To correct this error, the anterior teeth should be placed in an end-to-end position in the groove on the bite block. Another error similar to the previous one is the teeth posterior to the focal trough. As seen on the left photo, the patient's anterior teeth is positioned too far back on the bite block, and this results in the radiograph on the right. As you can see in the radiograph, the anterior teeth appears wider and out of focus, and their roots also appear to be cut off. Correcting this error will be the same as when the teeth is anterior to the focal trough, which is to place the anterior teeth in an end-to-end position in the groove on the bite block.
The next common error is head turn. The cause of head turn is due to the patient's head being turned slightly to one side and not centered on the bite block. As a result, the farther side from the receptor can appear larger while the other side may appear smaller. For example, the ramus and posterior teeth on either side of the image may appear larger than the opposite side. In order to get correct results, the dental radiographer must position the patient's head so that the mid-sagittal plane is perpendicular to the floor and the bite stick is centered on the midline. Then, the lateral head support must be adjusted to stabilize the patient's head position. The last patient positioning error is lump posture. As for the slump posture, it is caused by the patient slouching, slumping, or when they are standing with their shoulders back. Because of this, the cervical spine is seen as a radiocavity in the center of the image and blocks the diagnostic information. To correct this, the dental radiographer must task the patient to stand straight or to sit back straight. Additionally, the patient can also step forward closer to the machine, which pushes the patient's cervical spine to be straighter.